at Pediatrics. Let me first start off by introducing myself. My name is Brittany Rogers. I'm coming up on my 9th year of being a pediatric nurse practitioner. I've been in primary care at a federally qualified health center for all 9 years, so it is my bread and butter, and I am super excited to be talking to you guys about these things. I hope you all can walk away from today's talk with just a more solid understanding of some of the key concepts in pediatrics and how to apply them in practice. My goal here is that you would not just be memorizing things, but that you would really be learning those practical applications so that you can give your patients the best and safest care possible, because kids are not just small adults, they are so much more. So let's jump in. Let's see. Click to my next screen. There we go. All right, so a quick note, we are now certified by the ANCC to offer continuing education contact hours. So if you're joining via Zoom, you'll get an automatic email for that contact hour if you stay for the full hour. If you're joining through other channels, that's okay, and I'm super glad you're here, but just in the future, know if you want that contact hour, just go ahead and log in with Zoom. All right, a quick review of our learning objectives for today. The first one is that we would just learn more about what's normal and what is abnormal in pediatric patients, of course. We will go through how to assess, diagnose, and manage some of these conditions. I've got some really good questions for us to walk through about how to apply a lot of this in clinical practice. And lastly, as we're talking about these things, I really want to make sure you know also the red flags, just because we can't know everything as an NP, but we really can have a good solid understanding of what is within our scope of practice and how, when something is out of our scope, how to get our patients the care that they need. So I hope today is fun and interactive, and one of the fun ways we can interact is through these Slido polls. They are completely anonymous, and they are a really easy way to see how everyone's feeling about things. So if you can go ahead and either scan the code on your screen or log into slido.com and put in the hashtag PEDS4NPs. I'm going to go ahead and launch the first poll and give y'all a few minutes to respond. So if everyone could log in, I will switch to my Slido screen. And all right. It should be logging on. So now you guys, okay, great. Our first poll is just where are you joining from? So what state are you in? Or what city, what country, wherever you are. If y'all can log in. And again, if y'all need me to put the login one more time so you can see, but slido.com, hashtag PEDS4NPs. All right, so we'll go back to our, see if anybody is able to log on. I see somebody's typing, hooray. Florida, awesome. Welcome from Florida. Anybody else?
Hey, Brittany.
Yes.
Quick thing. So the slide has a different QR code. It's from the last PEDS lecture. That's where the confusion is. So if everybody wants to join, they can scan this QR code that you have up right now. And it's PEDS, hashtag PEDS review. This one says PEDS for NPs.
Oh, okay.
Because it's
Sorry, my
taking
bad.
people, I think it's taking people to the other poll. That's all.
Gotcha. Okay, so the hashtag is wrong. It is PEDS, hashtag PEDS review. So you should be able to see it on the screen, but we have some people joining, so that's great. Awesome. I think that's everybody who is answering for right now. Okay, so our next poll is another fun, just get to know you one. So it's who is in the audience today. And this is just kind of a general question. Are you a nurse? Are you an NP? Are you a new grad? Are you in practice? What's your background? And you can just kind of jot a few notes in there if anyone wants to respond to that one. Toronto. We got some more people commenting. Student NP, FNP, hi. New grad, awesome. Thanks for participating, guys. It makes it more fun for me so I can get to know you guys. I wish I could see all your faces. It's kind of hard being on my side and not being able to see all you guys. Studying for boards, nursing student, awesome. Well, I hope this was super helpful for everybody. Our next poll is what's on your study plan this week? So is there anything you're really focusing on or trying to accomplish this week? PEDS, okay, great. I'm glad we're on your study plan. I obviously think PEDS is really fun, so I think it's great to study PEDS, but pediatrics, I'm about to enter my pediatric rotation. Perfect, awesome. Well, I hope I have some good clinical tidbits for you. I love having students. I wish I could even have more people come with me. Asthma, blood responses. Okay, good. Some more people are typing, I think. GIGU, also super interesting. Cardiac, we have some good webinars about all of these questions and how to answer them and everything. Awesome. All right, so our last poll is, how confident do you feel seeing and treating common conditions in pediatric patients? And again, zero judgment here. Oh no, working on it. There's room for improvement. So by the end of this, I hope you'll be feeling more confident. But we are all here to grow, and kids can honestly be a little tricky. So it's just, wherever you are, that's okay. We are going to help you get where you need to go. Awesome. Well, thank you guys for answering. Oops, I went to the wrong one. Okay, let's go back to our slides. Thank you all so much for joining. So we're going to start out with milestones. So I really like milestones, starting with them first, just because development really is foundational for pediatrics. A milestone is just a term for a specific developmental skill or ability, which can refer to several different domains. You've got your social emotional domain, your language and communication domains, your movement, more physical development, and then obviously your cognitive milestones. So these early markers really tell us so much about babies and young children's development, and they can really clue us in if they're having problems. Sometimes these are like the first signs that something's going on and we've got to dig a little deeper. So I think it's really helpful to put the milestones on flashcards and really get them to just like stick in your brain, so you know what to look for with each age group. And I'm not going to read all of these, but I put some highlights up there of some of the ones that boards tend to like, or kind of those like buzzwords. But at 2 months, they're really starting to do the social smiles, and that's just them. When you're looking at them and cooing and making smiley faces, they're smiling, starting to smile back at you, and they may not do it every single time, but they're starting to do more of that. They're more observing others. They're holding their head up a little bit better, getting those neck and core muscles stronger. By 4 months, they're really getting good with their head control. They might get up on their arms a little bit more. They're cooing and kind of talking. They might chuckle a little bit. They're not like full on laughing, but they're starting to make little laughing sounds. They'll usually bring their hands to their mouths, and they're able to hold toys. They're starting to kind of like reach a little bit. They may not have like a good solid reach, but they're kind of like swinging at things. By 6 months, they're able to roll better, roll from their back to their belly. They can sit in kind of a little tripod position for the most part at first. They have their hands in front of them to kind of balance them. They can recognize familiar faces. They're really starting to laugh at this age. By 9 months, they're sitting well without support. They're starting to say ma, 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 da, 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 repeating consonants. They can bang things together really well. They've got object permanence. That's another one of those like keywords you want to remember. And that just means that if you drop something on the floor, you hide it under a blanket, they are going to start looking for it. So they're kind of like, oh, I noticed you dropped that. I'm going to go try and find it. The pincer grasp, that's a really good buzzword for 9 months. That's when they're starting to use their finger and their thumb really well. They do start to have stranger anxiety, another buzzword. That's when they're, getting more clingy to their caregiver. 18 months, they should be walking well. They're going to start using spoons and forks better than, they're saying at least 10 to 15 words. They can start to scribble on paper, obviously nothing meaningful, but they can get that motion down. They're starting to follow like one-step commands or simple instructions. They can put 2 words together by the time they're 2. That's an easy way to remember that. They should be starting to put short phrases together. They can point to body parts, at least a few. They're starting to notice when other kids are feeling sad or happy or other feelings are kind of showing. They can start to run and kick balls at this age. And while developmental milestones are regularly monitored at each pediatric visit, we do have more intensive screenings at 9 months, 18 months, and 24, 30 months. And that's when we have those more in-depth assessments. So that's like the MCHAT screening at 18 months and 24 months to check for autism. The PED screening is at 9 months and 30 months. So you're really getting more of those in-depth questions, but at every visit, you should be checking developmental milestones. Super important to know that if a child is not hitting several milestones, like not walking, not speaking, not making eye contact, or even regressing in milestones that they already hit, we're going to want to do a more in-depth investigation. And sometimes it's kind of mild, and other times it's a little bit more extreme. either way, really try and do your best to not make the parent feel like super nervous off the bat. So kind of just explain that you have some concerns. You want to get a more formal evaluation done, either in the office or with a specialist, to just help them get caught up and make sure they're getting the care they need. You know, obviously with peds, it's a really sensitive subject, and so you know, a parent with a child that is not meeting milestones is going to make them start to get nervous. So you just kind of be sensitive to what they're hearing you say. All right, and then some of the preschool milestones, and it cover those, but they're really starting to put on their clothes better by themselves when they're 3, 4-ish. They're playing with other children, as opposed to when they're 2, they're kind of playing alongside, and then when they're 3 and 4, they're really starting to play together. And by 3, they really should be about 75% understandable with language, and about 100%, close to 100% when they're 4. So you should be really able to understand them better. And then school age, obviously, they're doing more academic milestones. By this age, they're counting, they're doing numbers. They're able to follow the rules in a game. They can do simple chores at home. And again, like we said, those red flags, if they're missing milestones, we want to do those further evaluations. All right, so we have a practice question. An NP knows that a motor developmental milestone for a 4-year-old child includes, and I will hop up to our Slido real quick. What do you guys think the answer is? So, any thoughts on what the motor developmental milestone for a 4-year-old child is? And this is not select all apply, this is just one answer. Skipping and hopping, all right. Any other thoughts? Walking on tiptoes. All right, I think we're solid with choice B right now. I think so. Choice B is correct. Skipping and hopping proficiently on one foot is a motor developmental milestone for a 4-year-old. Another one would be like catching a ball. They should be starting to catch a ball at that age. Choices A, C, and D are not the right answer. I can see how it can be kind of tricky because they are actually milestones for a 3-year-old. So by 4, they should also be doing these things, but a milestone for a 4-year-old is choice B. All right, so a quick little break. I just want to introduce you all really quick to a couple of our exam prep tools. We have an awesome question bank. I know it says free trial right there. It's actually a free demo, so you can try some of the questions. It's not a 7-day trial, but it's a demo of some of the questions that we've got. Like we just did on the meeting milestones. We have On Demand, which is an amazing resource with really short, to the point videos that cover all of the most important content you need to know. And then our most comprehensive exam prep tool is the SurePass Pro. And this one includes everything you need for your exam prep. It's got the Q bank, it's got the on-demand videos, it's got live review, and even mentoring. So it's got that pass guarantee, so that you can really approach your studies with confidence, knowing that we've got your back, and we will make sure you we'll make sure you have what you need to know. So we're really committed here at Archer to providing affordable and effective resources to help you conquer your AANP and ANCC exams. Join our community and check out these amazing tools when you get the chance. All right, so we're going to jump back to screenings. So we've moved on from milestones. Now let's review screenings. Screenings are the use of brief standardized tests to identify children who may be at risk for health, developmental, or social emotional problems. And there are a lot of screenings, but there are a few that you need to know for newborns. And these include the newborn hearing screening, pretty self-explanatory. Babies that fail the first time, usually it's because they've got residual amniotic fluid stuck in their ear canal. And I would say most of them pass by the second try. But if they don't pass on that second try at their first visit, they'll need to be referred by the pediatrician to for a more formal hearing evaluation with audiologist. And they're so cute. When they're little tiny in the hospital, they put these little big headphones on them and strap them in, and they look like they're just little like babies going out to space or something. It's really cute. The next test that they will do when they're newborns is a bilirubin check or a jaundice screening. And this is just to make sure it's in a safe range. There's a great tool online. It's called Billy Tool that lets you put in their birthday, like the hour they were born, when you drew the Billy level, what results you got, and it gives you kind of an algorithm for treatment. So this is really helpful just for clinical practice. So remember bilitool. But jaundice occurs when there's too much bilirubin in the blood. An easy way to understand newborn jaundice is to imagine baby's blood is like a busy highway, and there's old blood cells that are broken down that need to be cleared away. And when they release this yellow substance called bilirubin. And in newborns, the liver, which is kind of like the exit ramp for this bilirubin substance, they may not be fully ready to handle all of it. And so it starts to just back up in their blood, and it can make their skin and their eyes look yellow. So jaundice is first noticed in the eyes and the whites of the eyes. Is also the last place that jaundice will go away. So it'll start in the eyes. It'll kind of progressively start to go down the body, get usually into the chest, sometimes in the abdomen. It'll peak on day 3 to 5, and then it will kind of start to go back up. So the eyes will be the last place that you'll see it leave. Treatment is just to feed them often. That helps flush out the bilirubin from the stool. Exposing them to indirect sunlight can help break the bilirubin down into a form that's more easily excreted. And then repeat testing, of course, depends on their clinical presentation, how well they're feeding, how well their weight gain is, kind of a number of different factors that as a clinician, you'll kind of learn when you need to rescreen or retest. And then the last one that you need to know for newborns is the critical congenital heart disease screening. So this is using pulse oximetry to check oxygen in your right hand, and then in either foot. Your right hand is a preductal site, so the blood flowing out of the aorta is leaving before it hits the ductus arteriosus, and then the foot is the postductal site. So it leaves the aorta after the ductus arteriosus. If it's 95% or higher, you're good. If it's lower than that in the hand or the foot, then you're going to have to do a retest in an hour. And then after 3 failed tests, after multiple, and after each hour, if it's been 3 times, then that's when they have to have a further evaluation from a cardiologist. And obviously, if they have other things going on, then they would need to be seen sooner. But definitely, if they fail their critical congenital heart screening. All right, so these are kind of just some tidbits you need to know about checkups. So at 2 months, 4 months, 6 months, and 12 months, or 6 months, 9 months, and 12 months. This is when we're really focusing on those growth charts. So the length, the weight, the head circumference, and then those early milestone checks. We check their head circumference until they turn 2, and then once they turn 2, you switch to checking the BMI. We also do finger sticks for hemoglobin and lead screening at 12 months, and then again at 24 months. Without these lead screenings, sometimes you have no idea that kids have exposure to lead. It's not very common, but I have seen a couple in my practice, and the benefit of this is you can catch those kids early, because if you have high or constant exposure to lead, they can have nervous system damage, delayed growth and development, cognitive issues. So you really need to figure out where they are getting exposed to, what source they have. Iron levels are evaluated through the hemoglobin check, of course. This is crucial because your iron stores that you're gathering during the 3rd trimester when you're in utero, the baby is, they are pretty much depleted by the time they're 6 months of age. And so you really have to encourage parents to do high iron foods or iron-rich foods when they start at 6 months. Breastfeeding infants are at higher risk just because there's really not a lot of iron in breast milk. But so by 12 months old, if these babies have not been getting a lot of iron-rich foods, they're at risk for iron deficiency anemia, or if they've also, sometimes kids will switch to whole milk too early and or drink a lot more whole milk than they need to, and that can be putting them at risk for anemia as well. So we check all of that. We have one more practice question to check. So a 4-year-old child presents to the clinic to establish care. The mother brings copies of all the immunizations and the last 2 office notes. The child was born without complications at 39 weeks and has no chronic health issues, so pretty healthy kid. The record reports typical milestones in development and occasional viral or ear infections, not uncommon. What screening do we need to do at this well-child visit? Okay. What screening is required for this patient? 4-year-old, pretty healthy, no chronic issues, typical milestones. Awesome. Y'all are on it. So choice A is correct. Vision screening should begin between the ages of 3 and 4. definitely by the time they turn 4, but you can start at 3, which is when children are generally developmentally capable of cooperating with the screening process. Detecting vision problems early is crucial because untreated issues such as amblyopia or lazy eye and refractive errors can lead to long-term visual impairment. So ideally, vision screenings occur annually, but at least every other year is acceptable if resources or access is limited. Hearing screening is also at the same age, so about 4 years old, if you can get them to cooperate with the exam. This is recommended to detect any early hearing deficits, which can significantly impact speech, language development, and learning if they're not addressed. Any abnormal result, obviously, we're going to want to send them to get the proper care that they need, either from optometry, ophthalmology, audiology, or any additional therapies as well. So choice B is not correct, the lipid testing. This child is not at risk, or we didn't get information that they were at risk. Routine lab screening for lipid levels starts usually between 9 and 11, and then they go again between 17 and 21, unless there's specific risk factors. So if you've done a lipid screening, like a questionnaire that says that they are at risk, then you would want to do the testing earlier, but normally not till when they're between 9 and 11. Choice C, a PKU testing is a genetic metabolic disorder that you screen for in newborns. So that early detection is crucial for that. If you don't check and you don't find out that they have PKU, it can lead to severe intellectual disabilities and other neurological issues. Symptoms usually will manifest early in life, so we don't need to test for that when they're 4. And then choice D is also incorrect. So TB testing is not routinely performed on all children. It's really only for those who are considered high risk, if they're living in or traveling to areas with a high prevalence of TB, or if they've been exposed to somebody with active TB. And in this scenario, the mom hasn't given us any indication that they would need a TB test. So, all right, let's go back to our slides. So now we will quickly talk about failure to thrive. So to introduce this topic, we have a scenario I'm going to tell you. A 6-month-old infant comes to your clinic for their well visit. They've been on the smaller side, measuring below the 10th percentile for both height and weight. But at this visit, they've now dropped down into the 5th percentile for length, and now they're the 2nd percentile for weight. So being the astute clinician that you are, you suspect failure to thrive, but what exactly counts as failure to thrive? So it can be a few different things. Failure to thrive can be less than the 5th percentile for weight based on their age, a decrease in more than 2 major percentiles on their growth curve, and finally less than 80% of the average weights based on their height to weight ratio. It can be caused by a few things: not eating enough calories, malabsorption of nutrients, conditions that require increased calorie demand. So you kind of have to start to do some digging, some really good questioning, sometimes being as specific as asking them, are you mixing your formula correctly? Because I've had some patients that are, completely over, like adding too much water compared to formula. And sometimes you can have them go ahead and write down the bottles that they're doing for 24 hours. With breastfeeding, obviously, you're going to want to make sure they've got a good latch. They're not too sleepy, making sure that they're waking up and eating appropriately. Malabsorption issues, obviously. Inflammatory bowel disease, you'll have other symptoms going on with that. Celiac disease, cystic fibrosis, all of those can cause failure to thrive. And then cardiac disease, cancer, anemia, some of those can all cause a baby to have failure to thrive. So once we found the reason behind failure to thrive, we can address it. Sometimes it's as simple as feeding the baby more often, or feeding them more foods that they like or we know that they'll eat. And the goal is to obviously gain the weight back. Sometimes they have to go to specialists to see what's going on with those underlying issues. So they may need to be referred out. But either way, we'll monitor the patients closely, checking their height and weight often to make sure they're getting back on track. We can get nutritionists involved, and just make sure that they're getting back on track. A warning sign. This is a slide that's all about autism. So obviously we started kind of talking about some of those red flags, but with autism spectrum disorders, the symptoms can vary really. There's a huge spectrum basically. So some children are living with relatively normal lives, and then others have very severe symptoms. They're nonverbal, they may not be able to care for themselves. So, we really don't really know why autism occurs. There's a lot of different underlying things that we're still studying a lot. Potentially advanced parental age, maternal obesity, or premature birth, but we're still learning. In terms of symptoms, though, they range so drastically, it can be hard to pick up on. So the common ones would be not meeting those developmental milestones, or if they've got milestones and then they start regressing. If they're really having a hard time communicating, they're not making a lot of eye contact, not responding to their name, not really interested in what is going on around them in terms of other people. They're missing some like facial expressions, social cues. They've got either repetitive language, sensory issues to light, sound, textures. They might start to develop kind of more obsessive or extreme interests. So we're trying to catch all these symptoms as early as we can to get them the help that they need. That's why we do those autism screenings at 18 and 24 months, the MCHAT screening. But if you have concerns before then, it's always okay to get them referred out for a more intensive evaluation earlier. All right, and autism is not a diagnosis, so you'll refer these kids to specialists like psychiatrists who will use the DSM-5 criteria, and that's the manual used to evaluate and diagnose mental disorders to make the formal diagnosis. I think the ICD-10 that I use a lot is kind of like autism, like spectrum symptoms, or it's not an official diagnosis, but they're showing symptoms or signs or symptoms of it. So there's lots of resources available to give these patients with tools to help with daily life for like behavioral therapy, exposure therapy to sounds and other sensory triggers with an occupational therapist, speech therapy to help if they have got speech delays. Some medications can help depending on what their symptoms are. So there's a wide variety of how we can help patients with autism. And as a primary care provider, you are kind of catching and screening that first and really getting them referred out to where they need to go. All right, on to vaccinations. So this is obviously a hot topic in today's world. The CDC's immunization schedule, though, is the roadmap for when kids should receive specific vaccinations to protect them from these serious and sometimes life-threatening diseases. The schedule is developed by the Advisory Committee on Immunization Practices, or ACIP, and they're reviewed and approved by the American Academy of Pediatrics and the American Academy of Family Physicians and other leading medical organizations. So go ahead and kind of start to make a mental note of when you start to give certain vaccines. Consider the timing of the vaccine. It really coincides with their developmental stage and their susceptibility to the disease at that specific stage of life. There have been some changes with the new administration regarding like COVID vaccine, with a recent decision from the federal government to remove that recommendation from healthy children and adults if they're 6 months and up. But really, we want to focus on what the latest guidelines say. So check the CDC website, but at this point, the COVID vaccine is optional. It says it's a shared decision between the clinician and the parent. So your job is to just be able to inform the parents that are interested about the benefits and risk and help them to make that decision. All right, so our next question, the NP prescribes administration of which vaccine for a term newborn within 24 hours of delivery? You guys know, which vaccine do you give them right when they are born? Hep B. I think we all probably get this one. Yes, they get Hep B when they are born. So we'll go back to this. So choice C is correct. The first dose of Hep B is given within 24 hours of birth for a term newborn. This really significantly reduces their risk of contracting the virus from an infected mother or from any other sources. The infant will receive the second dose at 1 to 2 months, usually at that 2-month visit, and then the third dose between 6 and 18 months of age. Normally at 6 months, though. For babies that do have moms who are with an unknown status or a positive Hep B surface antigen, they should receive the vaccine and the immunoglobulin within 12 hours of birth. So choice A, the MMR vaccine is incorrect. We give that one between 12 to 15 months, normally at 12 months of age. The second dose is usually given when they turn 4 or about 4 to 6 years age. Newborns do have antibodies passed from their mothers during pregnancy that help protect them until they turn 1. But it is good to know that with more measles outbreaks, you can get the vaccine as early as 6 months if you are in an area that does have an outbreak. Choice B is not correct. The Hib vaccine is given as part of a series, typically with doses given at 2 months, 4 months, and 12 months of age. The risk of serious Hib disease, which is usually meningitis, epiglottitis, pneumonia, that increases after those first few months of life. So that's why we really got to start giving it at 2 months. The highest risk period for Hib is between 6 months and 2 years of age. So we really want them to have some immunity by then. And then starting that vaccine series at 2 months aligns with the increasing risk and really ensures that they're able to be protected when they need to be protected. Choice D is incorrect. The IPV or the polio vaccine is administered as part of a series with the first dose at 2 months, followed by 4 months, and then again at 6 months, and a booster between 4 and 6 years old. So these also, the babies also get antibodies from their mothers during pregnancy. The risk of contracting poliovirus in the first few weeks of life is pretty low, especially in countries where polio has been eradicated or is pretty well controlled. So that timing is really just to make sure that they get the immunity when they need it as well. All right, we've got another practice question. The NP knows that infants can start receiving the diphtheria, tetanus, and pertussis or DTaP vaccine at what age? Nice slide up here. All right, so when can they get DTaP? Do you guys remember? Awesome. 2 months. Any other thoughts? All right, consensus is choice A. So infants can receive their first DTaP at 2 months. Infants and children younger than 7-year-olds receive the DTaP. And then once you turn 7 or older, then you get the Tdap. Choice B is not correct. They get that at 2 months. Choice C is incorrect. Starting at 7, like we just said, they can get the Tdap vaccine. And then choice D, obviously starting at 11, that's when they'll start to get other vaccines like the meningitis vaccine. Whoops. Yeah, back to my slides. All right. So let's talk a little bit about puberty. It is a hot board topic and obviously crucial to understanding growth and development in adolescence. So here's some lovely pictures of the growth and development that we need to know with Tanner staging. So be super familiar with these Tanner stages and what the sequence is for both males and females. The first and the last stages are more easy to remember. It's really just making sure what's happening in those 3 stages in between. So stage 1 is prepubescent. Stage 5 is sexual maturity. So in females, during stage 1, there's no physical findings. There's no pubic hair, no increase in breast size. By stage 2, we'll have some new changes, some sparse hair, fine, downy pubic hair is what they call it, along with a palpable breast bud under the areola, and a slight increase in testicle size in boys. Stage 3 is where you're really starting to see more true changes. You've got increase in darker, more coarse pubic hair. For the girls, we'll see an enlargement in the breast tissue. And in boys, we'll start to see that enlargement in the penis and in the testicles again as well. In stage 4, we start to see more adult-style pubic hair around the genitals. So stage 4, we have the development of the areola, the projection of the areola above the breast tissue. And in boys, further growth of the penis and scrotum with the development of the glands. This is that part around the head of the penis. And then stage 5, marks sexual maturity. So that's when the pubic hair is adult size and shape. This is usually one of the key clues that they've fully undergone puberty. They might have hair on the medial thighs as well. And for females, we'll see the areola flush against the breast tissue again, the areola hyperpigmentation or that darkening, and then the nipple protrusion. And for males, the penis and scrotum have reached the adult size and shape. So here's some lovely pictures of males Tanner staging as well. But again, kind of just like get these in your brain. This is not a Slido poll, but remember, which one comes first? Testicular enlargement or penile enlargement? And the answer is testicular. They will get that first before they get penile enlargement. So our next poll, a 13-year-old male presents to the clinic for his annual exam. The patient reports his breasts are becoming larger. Upon physical examination, the nurse practitioner noted bilateral breast enlargement with no masses. Besides the bilateral breast enlargement, the NP notes that all systems are within normal limits. Which of the following is the most appropriate intervention? All right, so our next poll. So what would we do for this patient? 13-year-old male, has breasts that are becoming larger. Pretty much all the other exam symptoms are normal. There's no masses felt. Awesome. So we are going to notify the patient that breast enlargement is a normal finding in this patient. So gynecomastia is transient and benign bilateral or unilateral breast tissue enlargement. And it commonly occurs sometimes in infancy, but in adolescence as well, and it's due to hormonal imbalances. Gynecomastia can occur in puberty, and it resolves without treatment. You don't have to do anything between 6 months and 2 years. So it can start to develop between 10 to 12 years old, and then commonly occurs between 13 and 14 is when you'll see it more. If gynecomastia does persist more than 2 years, or if it causes a lot of extensive embarrassment, plastic surgery is an option to address the cosmetic and psychological concerns. Other causes of gynecomastia can include medications, so check in and make sure that they're, see if they're taking any medications like spironolactone, ketoconazole, cimetidine. Obviously, if they're using any anabolic steroids or any illicit drug use, we're going to screen for all of that as well. There's also something called pseudogynecomastia or false gynecomastia, and this doesn't have anything to do with puberty or hormones, but it's when a male has extra fat tissue in the chest area, and that makes it look like they have breasts. But the difference in gynecomastia is that there will be growth of the actual breast gland tissue, whereas in pseudogynecomastia, it's just fatty tissue. So choice A is incorrect. Gynecomastia is the result of a hormonal imbalance between androgen and estrogen. And so testosterone might aggravate gynecomastia. Choice B is incorrect. The drugs that block the effects of estrogen, such as tamoxifen or viloxifene, are currently not approved by the FDA for the treatment of gynecomastia. And then choice C is incorrect. Gynecomastia is commonly seen in males during puberty and resolves without treatment within 6 months to 2 years. So they do not need to be referred to an endocrinologist. And moving on. So now we know what normal puberty is. Let's talk about what happens if it occurs too early. So for girls, that would mean secondary sex characteristics before age 8, and for boys in age 9. Causes can vary. It is important to note, though, that it's been recognized on average that African American and Hispanic girls may start puberty somewhat earlier than white girls, so they have an increased likelihood of having precocious puberty. And in both boys and girls, the adrenal glands, the small glands that sit on top of the kidneys, they can start producing weak male hormones called adrenal androgens at an early age, and that causes pubic and sometimes axillary hair and sometimes body odor. And this situation is called premature adrenarche. It is benign and does not require treatment, but you still need to do the proper tests and labs and imaging to make sure that we are ruling out anything else concerning. So you'll do a physical exam, you'll do your bone age assessment, you'll do your hormone levels, and then obviously treat the underlying cause. So next question, which of the following children exhibits precocious puberty? So we've got a 10-year-old boy with enlarging testicles and pubic hair, 10-year-old girl with menarche, 7-year-old girl with sparse pubic hair on exam, and then a 6-year-old boy with 2-centimeter testicles. What do you guys think is the answer? Any thoughts? Excellent. Thank y'all again for participating. It really helps. And it's fun. All right, so we got choice C is correct. The 7-year-old is exhibiting precocious puberty. because she is experiencing the secondary sex characteristics prior to age 8. Choice A is incorrect. That's normal puberty. Choice B is incorrect. Also normal puberty. Choice D is incorrect. This is also normal. Before puberty, the testes typically measure less than 2 centimeters in length. And the first sign of puberty in males, known as gonadarchy, I think I'm saying that right, is testicular enlargement, like we said. And this usually corresponds to a testicular volume of about 3 mLs or more, and a length exceeding 2.5 centimeters. We will head back to our screen. So we talked about precocious puberty. Now let's talk about delayed puberty. So signs of delayed puberty in males would include the penis and testicles not starting to grow larger by age 14, genital growth that takes longer than 5 years, or shorter stature compared to their peers who are now growing faster. And in girls, the signs can be no breast development, by age 14, or not starting to menstruate within 5 years of the breast starting to grow, or by age 16. The causes, I mean, the most common one I would say is a family history or like a constitutional growth delay, which is late bloomer. But it can also include nutritional deficiencies or being malnourished. You can sometimes see this in teens with eating disorders or athletes who aren't eating enough. So they're really just not getting enough calories, and they're leading to nutritional deficiencies. Some conditions like sickle cell, cystic fibrosis, some chromosomal abnormalities can cause this as well. The diagnosis, again, will be that physical exam, the bone age, hormone levels, and also the evaluation of their nutrition. And depending on the cause, they may need a referral to endocrinology to start hormonal therapies, but you kind of got to get to that cause of what's going on. I just realized I left my timer on. Sorry about that, guys. So our next question is, what chromosomal abnormalities are known to cause a delay in puberty? So this is a select all that apply question. Do you guys know which ones can cause a delay? Awesome. Any other thoughts? Nope. All right. Choices A and C are correct. So Turner syndrome is a genetic abnormality in females that results from missing the X chromosome. Females will present with delayed puberty or failure to have menarche. They're typically short. They've got that kind of webbed neck. They may have coarc of the aorta. They've got the shield chest with widely spaced nipples. Klinefelter syndrome is a genetic abnormality in boys that results from an extra X chromosome. So they will present with delayed puberty, and they are typically tall. They've got small testes, gynecomastia, long legs, and short arms. Choice B is incorrect. McCune-Albright syndrome is a condition affecting the endocrine, skin, and bones that can cause precocious puberty. And then I'm not going to say this right, testoxicosis is a familial male-limited precocious puberty. And that's another name for it, familial male-limited precocious puberty. So it's a condition that causes precocious puberty in boys between ages 2 and 4. Whoops. Back to my slides, sorry about that. So one more check-in. Wanted to make sure everyone has the info that they need to contact us here at Archer. So you can reach us at nursepractitioner@archerreview.com. We are here to help you with everything that you can possibly need. So please connect with us if y'all have any questions. There's our email down at the right bottom hand of the screen. You can also connect with us Instagram, Facebook, LinkedIn, TikTok, all of those. We've got tons of great information coming out, so please check those out. Again, like I said before, we've got the Q Bank that's amazing. It's got over 1,600 questions in there. It's got a readiness predictor, so it will let you know after you're doing test questions how likely you are to pass your exam. Amazing. Those on-demand videos are awesome. They are really right to the point. It's not like you're watching this super long video. You kind of can click on the ones that you need and get the information that you need. Live reviews. We will start to post when we do have live reviews coming up. And then obviously the SurePass has all of it. So it's got the Q Bank, the on-demand videos, the live review, and the mentoring with that pass guarantee. So check those out on our website. And if you have questions, please shoot us an email. All right, so we are getting close to the end. You guys are doing awesome. I know it's the end of the day, or at least it's the end of the day for me. 7:45 where I am here in Georgia. I don't think I told you guys that, but I'm in Georgia. This is our last patient we're going to go over. So this is Sarah. She's 12 years old. She's a female. She's about the 30th percentile for her weight or 50th for her weight and the 30th percentile for her height. She is a well-nourished adolescent. She has no distress. She is in the office today with mild back pain. So she recently had a growth spurt in the last 6 months. She started menarche 2 months ago. She's up to date on everything else. Her dad did have scoliosis as a teenager that didn't require any treatment. Her mom was healthy. So now that we have this information, what do we do next? What is our next move with Sarah? Any thoughts? And you can kind of just type in anything that you're thinking. After you've gotten that basic information, where do you go from there? Any thoughts? I see one person's typing. And this is, again, there's not necessarily a wrong answer. This just is kind of, if you were in clinic and you saw this patient, what would you do next? So we would get an x-ray, check her for scoliosis, the bend forward test. Okay, great. So y'all are already moving on to scoliosis, which is great. But I would first do the old cart. So do our further health history. So we would be asking that onset, location, duration, characteristics, aggravating factors, relieving factors, treatment. We got some of those already, but kind of going through that full list. And as it turns out, we get more history on Miss Sarah. And we find out that the school nurse did recently identify a possible spinal curve. Sarah says that her pain started a few months ago. It's located in the lower back bilaterally, comes and goes, aggravated by prolonged sitting or standing. And she does not have any weakness, numbness, or limitation in her daily activity. So what are we thinking now? It's at the top of our list. You guys kind of already said this one. I'll move the slide forward, but I think everyone was kind of in agreement that scoliosis was the next thing that we were worried about. Any other thoughts other than scoliosis that you would think of with the patient that has these complaints? Or what else you would list in your differentials? Well, you guys were hitting it right on the head with scoliosis, so we will move forward with our scoliosis. I see one person typing. Trauma. Yep. So I mean, back pain, you're gonna want to identify what's going on in there. So we do a physical exam, and it shows that she's got the uneven shoulder height. She's got the right scapular prominence with a normal neuro exam and no leg length discrepancy. And we did do that Adams bend forward test, like we had said, like someone had mentioned before, which is great. So what do we need to do next with this patient? Breast tissue can cause back pain. You're right. So evaluating the breast tissue would be a great thing to do. And you know what? I don't think we have our next poll. So what do we need to do next? You guys are right. We need to order imaging. So we're going to do the standing PA and lateral spinal exams. And that is how we get our confirmation. Let me go to my next slide. Let me see if it'll go. So we've done I think we were just talking about this. I'm sorry. I think I got mixed up with my slides, but the asymmetrical, when you're doing your exam, if they've got, you want to have them stand with their feet together, their arms by their sides, make sure they're relaxing their shoulders. And that's how you can see if they have uneven scapulas or if their shoulder height's uneven. So just like straight on looking at them, inspection. If they're already off a little bit, that's one clue to scoliosis. If one hip is higher than the other one, you're going to want to do that Adams bend forward test. And that's the far right picture. But we're going to look with them. I usually tell parents or patients to do their hands in like a little praying position and go straight down and kind of have them go slowly so you can really see how the spine bends. Again, with their feet together, have their toes even, and make sure they're keeping their legs straight. Some kids will kind of start to bend those knees forward, so just make sure their legs are staying straight. And this will suggest any rotational deformity. If you do notice an abnormality, it's really good to have a scoliometer in practice. So get your scoliometer out and check the angle. And if it's 7 degrees or more, that's when you definitely need to go ahead and get an x-ray. But again, check their leg length. So kind of hop down on the floor and check their knees and make sure that everything is in alignment with their legs as well. So based on the x-ray that they get, you'll get a Cobb angle. And if their Cobb angle measures less than 10 degrees, then it's not considered scoliosis. If it's 10 to 25 degrees, that is mild scoliosis. Typically, that just means they need observation. So you'll recheck it every 4 to 6 months. The mild patients don't necessarily need to be referred out, but if you're feeling like they're kind of borderline and you'd rather them be evaluated by orthopedics, that's totally fine to go ahead and refer if it's mild. And usually the orthopedic doctors will do the same. They'll just recheck again every 4 to 6 months. 25 to 45 degrees is moderate. So this is moderate scoliosis typically needs a brace. So obviously they would need to be referred out. Greater than 45 degrees is when they'll get evaluated for surgery. So this is like pretty dramatic scoliosis. That is when they're going to need surgery. Consider an MRI though if the onset is before age 10. If it's really rapid progression, so if you see them when they're 9 and then all of a sudden they have like a very twisty back when they're 10, or 10 to 11, then you're going to want to consider an MRI. If they have any neurological signs, or if it's a left thoracic curve, that's a little bit more rare in idiopathic scoliosis, so consider that as well, and or go ahead and refer them. Education with scoliosis is big. Obviously, if you're referring to the orthopedic specialist for bracing, you can let them know kind of how often they're gonna be evaluated, how they're gonna get repeated spinal x-rays. If it's a mild curve though, and since Sarah's in the early stages of puberty, no treatment is required for her right now, but you can discuss, stretching is really good for scoliosis, strengthening. So you can do physical therapy if they're able to do that. Some people have limitations with getting places and that's hard. So if you can go ahead and print out at-home workouts for them, that's really helpful. And then if they do have back pain, using NSAIDs for pain as needed. I always discuss carrying their backpack correctly, so making sure they're using both straps. Some kids like to just hold one strap and then it kind of leans their body to the side. And so holding 2 straps and tightening the straps down so that the backpack sits higher on their back is better for them. Screen time is also important. So obviously with today's day and age, we've got a lot of kids that are kind of hunched over all the time, or they're on computers typing all the time. So if you can have them lift up that screen so that it's more like kind of in their face as opposed to having them hunch over and look down, then it's better. Curves less than 25 degrees, again, are typically moderate without intervention, and then greater than 25 degrees is when they're going to start to need potential bracing. And again, I think we have talked about physical therapy, pain management, follow-up. So those are all our main points we need to look at with scoliosis. So we have come to the end. Let's see. And our exam, again, I think this is where I was getting all mixed up with my slides, but our exam does not confirm diagnosis of scoliosis. You've got to get your x-ray to confirm. Okay, so our last question, how confident do you now feel seeing and treating common conditions in pediatric populations? Anyone feeling any better? Feeling a little improvement in our scores? Yay, I see a happy face. That's good. Awesome. 2 happy faces. I hope it's helped you guys a little bit. I could talk for hours and hours and hours about peds, so it's hard to honestly get what I want in 1 hour. But I'm glad that you guys are seeing some improvements. I hope that your studying goes well for the rest of the week. And if y'all, again, have questions, please let us know. We've got one more post. If there's any other topics you guys want to see, please jot them down if you want to write them here. If you think about something later, email it to us. We want to make sure y'all are getting the information that y'all are excited about and need to study. So if there's any other topics you want us to cover, please let us know. We've got coding and billing. That is definitely on the list. A lot of people have been requesting that one. So we're working on that. Again, log into our channels to see kind of what's upcoming. I'll go back to our psych on demand 3-day lab review. Working on that one. Here is our login information again. If you're trying to connect with us, please do. Let me go back to my Slido to see if anyone else had anything else. Dyslipidemia. Okay. I will make note of all of these and pass these along so that we get those on the board. If anyone has any other questions, please let us know. But it was wonderful chatting with you guys. Thank y'all again for joining in on Slido. I hope y'all have a great rest of your evening. And that is the end of our webinar.